Good afternoon, everybody. I think we're ready to go. Can I say hello and welcome you all to the Hounslow Health and Wellbeing Board. I suppose I should say Happy New Year, really. Yeah, it's not too late to say Happy New Year, but I'm going to say it anyway. Happy New Year, everybody. And we'll probably just start off with some quick introductions. I'm Councillor Lily Bath. I'm the Cabinet Member for Adult Social Care and Health and Public Health. And I chair this Health and Wellbeing Board. So if we go towards the right, shall we go with you and then we'll carry on? Thank you.
I'm Stephen Forbes. I'm the Executive Director for Children's and Adult Services here at the Council.
Hi, I'm Chris Hilton, the Chief Operating Officer of West London Trust, the community mental health provider here in Hounslow.
Martin Waddington, Director of Integrated Care and Commissioning for the Council and the ICB.
Peter Goulding, Health Watch and also a local resident. Thank you.
Amit Gupta, Hounslow Borough Medical Director.
David Chilling-Girian, Senior Public Health Strategist.
Lynn Gray, I'm the Primary Advisor in the School Effectiveness Team and Team Leader for Early Years.
Hi, I'm Jen Bullis. I'm a Senior Public Health Officer within the Children's, Young People and Sexual Health Team at London Borough of Hounslow.
Hello, I'm Poppy Lane. I'm a Public Health Officer in the Children and Young People's Team.
Hi, I'm Josephina Abidu. I'm one of the Senior Public Health Officers in the Public Health Team.
Good afternoon, my name is Toby Lambert. I'm the Executive Director of Strategy and Population Health for North West London Integrated Care Board.
And good afternoon, I'm Kelly O'Neill. I'm the Director of Public Health for Hounslow.
Thank you, everyone. I will take apologies, and I only have one apologies, and that's Councillor Samia Chowdhury. Are there any other apologies? No?
No, there aren't.
Okay. Can I just also remind you, I should have done that at the beginning, we are actually recorded. This is live streamed, so you might just want to have a think about behaviour. I know you'll all be very well behaved, but just to warn you. Okay. Okay, in that case, are there any declarations that anybody needs to sort of declare? Declarations of interest? No? Okie dokie. All right, in that case, we'll go on to agenda item 2, and that's the minutes and matters arising from the last meeting, which was held in October. What I will do is I'll do minutes, accuracy and matters arising at the same time, just to sort of save time, if that's okay with everybody. So if we look at page 7, okay. Just looking at anything there on page 7? No? Page 8. I think there is an action, if I'm correct. We had Modesta and Pauline, didn't we, from the giving us an update on rough sleepers. Is there an action here, or is that on the other page? Oh, yes, I've just circled it on end of page 8. Stephen, did you manage to link up with the homeless? It's all right, I spotted it, yes. Okay. Okay, so that's good. Thank you. Anything on page 8? Do you want to comment on the action?
I think Pauline, at the last meeting, Pauline Jones and Modesta spoke about the council's development of the housing and rough sleeping strategy. That work is progressing through the organisational routes that have been set up to support that, as they described at the last meeting.
Thank you, Kelly. In that case, let's move on to page 10. Any matters arising? Any accuracy issues? No. Welcome, Councillor Sampson. We're just looking at minutes and matters arising, and we're on page 10. Is there an action around? That's more of it's more of a general, isn't it? Nothing specific as far as I can see. Okay, page 10. Again, there's an action for you, Stephen. I think that is similar. Page 11, sorry, yes. Yeah. Okay. Okay. Thank you. Page 12. You've got the Better Care Fund and we've got the Health and Wellbeing Strategy update. Page 13. Anything? No? Okay, so if you're happy with that, I will sign that off as an accurate record. Is that okay? Yeah, brilliant. Thank you. Then let's move on to agenda item 3, and we've got a lovely team, a whole load of you from Children's Services. We're going to talk about, I think David is going to do an introduction, and then you're going to give us an outline on the progress that you've made today. Thank you. I'll hand over to you, David.
Thank you, Councillor. So today we're going to talk you through our progress against the children and young people's priorities of the health and wellbeing strategy. Our colleagues here today own and are responsible for a number of sections of that strategy, and they're going to talk against a number of slides, and we'll pass between ourselves as we go through. Thank you. So, as you can see in this slide, we talk about some of Hounslow's demographics regarding our children and young people. A quarter of our residents are children and young people, and their wider families use and interact with a range of council services and NHS services. As we know, Hounslow is a great place to live and work with a wide range of assets. However, some 17% of children do live in income-deprived families, which is a major barrier to them achieving the best health and development opportunities they could achieve. And today we're going to present a snapshot of children's wellbeing from an early years perspective, through taking you through a journey of infants' wellbeing up to being school ready. So we're focusing on the earliest stages of life. We're not intending to exclude any of the very wide-ranging support services across the borough, and we'll explain where children benefit from a range of selected touchpoints and help and support and healthcare specific milestones that are included and measured for impact in the health and wellbeing strategy. And here we'll give a context and examples of services and system action that can intend to give them the best start in life. The best place to start for that is the Healthy Child Programme. And the Healthy Child Programme includes health visiting and the school nursing service, a service to all families with children. Here, specialist nurses provide key universal mandated health milestone checks of infants up to 2.5 years. With the level of services they receive dependent on the family's need, and a targeted offer is available upon meeting certain criteria. They have a core health promotion role. The staff have a core health promotion role, and the services focus is on the best start in life, school readiness for school, and preparation for a healthy adult life. The contract was recommissioned last year and is with West London Trust, and it's the largest contract within the council's public health grant. The decision was made to renew that contract and remain with our current provider and its brilliant workforce. We work closely with them to co-design the service that focuses on high quality delivery of the universal provision against those national indicators and local priorities. The service improvement and value for money are a big focus of achieving that. Our ongoing partnership is due to several considerations, including the provider's knowledge of the local borough and the community, and their ability to deliver against local children and young people's public health priorities. Key to that is their enthusiasm to work towards the key service improvement areas. And these last 18 months have seen significant improvements to key indicators of performance. We've highlighted a box there on the slide, which describes some of the areas that we've RAG rated of exceptional delivery, and some orange.
Is it appropriate to ask questions as we go through, or would you like them held to the end of the presentation?
Would you prefer at the end?
We prefer at the end because obviously we might slow down too much.
Exactly. Yeah. We've got about 45 minutes for this, so we've got enough. Yeah, I think that's probably easier if that's okay. Thank you.
No problem. So we've RAG rated those there. Some of the orange ones are notoriously difficult to shift up across many boroughs in London. But with our focus of continuous improvement and service improvement plan, we have developed, we're going to streamline that process and refresh those pathways to improve quality and service delivery. Thank you. So With regard to the Healthy Child programme, I want to break down some recent progress into separate parts, 1 and 2. First is the service development work we've been doing with our providers at West London. This collaborative approach was taken with the provider to develop new and refreshed performance indicators for the service. These looked at our statutory indicators and the service quality and the staff caseload and their time. Here we've also included more opportunities for narrative feedback to better show the health prevention work in the service. And it's this which will help us to move those RAG-rated indicators back into the green zone that we want. The result has been a refreshed list, which allows us to have greater ownership and discussion and development. We're working with the service to ensure that the service delivery covers both the Healthy Child programme priority areas, those national targets, and also keeping it localised related to our areas of inequality and focusing on where help is needed most in the borough. Second point there in the slide, well, actually I should mention one in blue, the link. Do watch, please, the video that promotes the 0 to 19 service. It's a great video which really describes brilliantly how our health visitors are well connected to the community and are well liked by residents. Our contribution in the public health teams to this joint work of service improvement is to provide an opportunity for working groups to develop opportunity for staff across the multidisciplinary teams to come together under 3 thematic areas of area improvement that we're all responsible for achieving. And those you can see are titled there. We're undertaking groups around health and education settings, one around parental support, and the last around infant feeding. And upon those 3 themes, my colleagues will describe work they're doing currently and how they'll feed into those working groups, and together with professionals seek to find those solutions that we need. Thank you. Next slide. I'll pass to my colleague Jen, who will take us through a journey of an infant from birth to their 2.5 years. Thank you.
Thank you, David. So here we can see that pathway or journey for those first 5 years of a child's life in Hounslow. So from when they're born right through to when they reach the school gate. We've included here the common health issues which impact our children and families to show the typical challenges and how we impact them through our cross-cutting work in public health. These challenges, it's important to note, might not impact every child and family, but they do often occur within our communities within the borough. So we're going to start with maternal health, looking at how our baby, who we're calling baby M, is before she gives birth. So how are mothers and birthing persons in Hounslow? What we've noticed from some data that we've gathered lately is that based on mothers that have their weight recorded during their booking of their pregnancy, up to 52% of these mothers and birthing persons are overweight or obese, and that this can impact childbirth and lead to things like an assisted delivery with forceps or difficulty giving an epidural. We also know that mothers that have a high BMI are from particular backgrounds, including the South Asian, Black and African Caribbean community and the Middle Eastern community, or those that have had a baby over 10 pounds at birth, can develop gestational diabetes, which can lead to the difficult labours that we describe, but can also lead to caesarean section, prematurity, preeclampsia, and heart and breathing difficulties for their babies when they arrive. We do note that for those that have their smoking status recorded when they book their pregnancy, around 5% of mothers smoke at time of booking, and that reduces to 3.4% at the time that they deliver, which is significantly below the England average, but we know that might be an underreported health risk. We know that smoking is a known risk during and after pregnancy and can impact things like what we call SUDI or SIDS. We've undertaken the maternal health and infant mortality report, which has a sort of 2-pronged approach to recommendations based on the data that we've been able to gather so far. This looks at the more acute health behaviours in families and also at the wider determinants of mothers' and babies' health. Our local primary care network at Great West Road is undertaking a very interesting project at the moment, looking at the early identification of gestational diabetes, which is a key risk for women that are becoming pregnant, to see how we can better identify that early. And we also are locally implementing the ICON programme, which is there to support the emotional well-being of young families to prevent non-accidental injury to an infant. We're looking at how we can develop good health preconception through the Women's Health Strategy, working across services to improve maternal, physical and mental well-being, to support our healthier pregnancies, healthier households and healthier little ones when they arrive. So it's now our birthday. So let's learn about how Hounslow's babies are at birth. So as we mentioned, we've taken a look at our maternal health and infant mortality insight report, which we've drafted. And that shows that babies in Hounslow are more likely to have a low birth weight at the time that they are delivered at full term. It's around 4% of our babies. And that this is particularly high within, at present, as we've noticed, within the ward of Hounslow Central, which is an area where poor health is more typical than other wards. It's a target location for a lot of our activity that we look to undertake. Low birth weight does contribute to a lot of poor health outcomes, including infant mortality, inhibited growth and development, and also other diseases later in life. So it's something that we really want to avoid. It's linked to things like smoking in pregnancy, substance and alcohol misuse, nutrition during pregnancy, but also mother's age and ethnicity. We know that we've done some really significant work around the uptake of Healthy Start vouchers in London Borough of Hounslow, and we've seen a significant increase in uptake, but it is still lower than what we would expect it to be based on the need of our community. It's around 65%. So working to increase that uptake would really help to improve the nutrition of mothers and the nutrition of their little ones, improve the quality of breastfeeding and the length of time that they can breastfeed, and the knowledge and availability of food as they move towards solids for their little one. We have, as we've mentioned, the prenatal parenting and early childhood development working group, which is really going to help support collective work across services, sharing key training and information, and new approaches that we can work with together. I will now hand on to my colleague Poppy.
Thanks, Jen. I'm going to talk to you about breastfeeding. So you can see on the two purple charts there, the breastfeeding rate at 6 to 8 weeks broken down by LSOA, and then on the right of that, the breastfeeding rate at 6 to 8 weeks broken down by ward. Our breastfeeding rate at 6 to 8 weeks is not 77.5%, as you can see there, but it is 61%. That 77.5% figure has been taken due to total breastfeeding and partial breastfeeding, and it's been added together, which has made that figure. So despite that being lower than what is on the slide, our Hounslow breastfeeding rates are 10% higher than the national average at 61%. And our breastfeeding initiation rates are very high at 92%, although there is that 30% drop off by 6 to 8 weeks, which shows us that most mums and birthing parents do want to breastfeed or chest feed their babies, but for a number of reasons are not able to, and that may include lack of support. Since 2021, we've had significant investment in the breastfeeding support offer via the Family Hubs project, and since that project has begun, we've seen a 20% increase in the breastfeeding rate at 6 to 8 weeks. In our recent hospital UNICEF Baby Friendly Initiative reaccreditation, where we achieved level 3, we saw an increase from 9% of parents reporting having had a feeding conversation antenatally in 2022 to 90% in 2024, so really positive there. And we have also just had our community level 3 accreditation, which we passed with flying colours, and we are set to be gold accredited, which is the highest level of accreditation, by our next accreditation in a few years. Full details of our future plan for the breastfeeding offer from 2024 to 2027 is to be published next month in the breastfeeding delivery plan, and that the delivery of the outcomes in that plan is to be led by the infant feeding steering group, which is soon to become the infant feeding working group, as mentioned by David earlier. So good news there for the most part. Some slightly less good news in terms of childhood vaccination uptake, unfortunately. So our childhood vaccination uptake in Hounslow is below the national average across all vaccinations. And for example, that is represented in our MMR statistics. Our MMR1 uptake at 2 years old is 87.1%, and our MMR2 at 5 years old is at 78%. So there is a drop off there, and that needs to be in the 90% range for herd immunity. We have done made extensive coordinated effort in the last couple of years via the Hounslow Immunisation Group and partner organisations that attend that, in understanding why this is and trying to coordinate an improved uptake and access for families to those vaccinations. we have done a lot of engagement with those families and found that there is both hesitancy and complacency, and so we're working with a particular set of those communities, for example the Somali and East African community, to understand why it is that vaccinations are not something, or is something that they might prefer to avoid or say no to, and increase that uptake, work with those groups to increase that uptake. We've also done a similar piece of work with our health visitors to understand their own perception of vaccinations and if the sort of current zeitgeist of vaccination rhetoric has affected their own practice and how we can help them to promote vaccinations. Thank you.
Okay, so I'm going to talk to you here about the 0 to 4 A&E attendances. So Hounslow has one of the highest levels of unplanned A&E attendances in London and in England as well. We've learned that families in Hounslow often access A&E due to a range of preventable early childhood illnesses and manageable concerns, so fever, cough, cold, and as well as some feeding issues with babies, so those who struggle to keep their milk down or have a poorly tummy, and babies who also go to A&E for jaundice as such. And we believe that many of these attendances can be manageable without acute care. As a whole system approach to try and tackle the issue and to help reduce the burden on our A&E department, we initiated a working group which consists of our hospital colleagues, our community offer, so health visiting team, children's centres, as well as working with our NHS primary care colleagues and third sectors to try and understand why our families are attending A&E rather than utilising some of the other services that we have. We have identified that some parents choose to go to attend A&E due to often limited capacity within primary care or the lack of their understanding of other healthcare services available to them. And there's also been other health literature, some literary reviews that have evident that this is due to parental anxiety. So, for example, there could be first-time parents, so they just seeking reassurance from a specialist. From a specialist. Our data dashboard also indicates that babies under 1 year accounts for 33% of these attendances, and we know that deprivation, the child's ethnicity, background, and the close proximity to the hospital has an impact on the likeliness of them to go to A&E. So in response to this, we're currently working a set of objectives within our action plan, which includes reviewing and improving our health literature resources. And so we'd like the same information and message given across all organisations. So we want to really promote some of the services, such as infant feeding sessions and like the Healthier Together website, which will hopefully support the self-management of childhood minor illnesses and redirect residents to the most appropriate services to them. We'd also like to optimise on Hounslow's existing assets, so for example, from peer-to-peer support. We're also scoping out effective models, both outside where there are lower rates of A&E attendances, and also within Hounslow, so those of where there may be some good effective practices already that we can kind of share across the borough, so we can effectively review and improve our care pathways between the emergency department, primary care and community services, and also decrease our discharge, improve our discharge pathways to reduce re-entry to A&E.
I'm going to talk about the ASQ, the Ages and Stages questionnaire scores at 2 and 2.5 years old in Hounslow. Children in Hounslow currently rank lower than their peers in other local authorities in the Ages and Stages questionnaire. This is a screening tool which focuses on communication and language, personal and social skills, problem-solving skills, and physical and motor skill development. The use of this screening tool at an early age will enable professionals to identify possible developmental delays, learning disorders, behavioural and social emotional problems, which in turn can affect and impact a child's ability to engage well in structured education settings. Young children who attend a preschool, nursery or childminder could have these needs picked up more timely and intervention promptly served to close any of these significant developmental gaps. For example, a particular group that we track are children who are perhaps part of a child protection plan children in need. These gaps are often greater than their peers. So through this co-production and cross-service approach and tracking, this developmental delays can be picked up more quickly. A focused approach to the ages and stages questionnaire skills development will be a really useful part of the broader work that is currently being undertaken across services around school readiness and children's readiness to learn at school. Therefore, there will be a greater impact being seen through this early identification and support in a child's life. Communication and language, we know, continues to be an area of low on-entry attainment for preschool and nursery children, with referrals to speech and language therapists continuing to increase. Early identification through the use of this screening tool can aid young children's development in this area, and so identification referral to support for children and families can be seen more quickly. This is especially true for those families attending our family hubs and children's centres, because these children are not yet attending a preschool or childcare setting. Thank you.
I'll just talk you through some action around child healthy weight now. So the prevalence of excess weight in the borough is higher for reception children at 21% and year 6 children at almost 40% than the England average. And although data showed earlier on that maybe some of our children may be born smaller, about a quarter to a third of those children are of an unhealthy weight by the time they leave year 6 into secondary school. It's a problem that solution sits with multiple agencies and partners to contribute to a healthier environment, conversation around a healthier weight and talking about weight in a positive way, and also to help children enjoy good food, which parents want them to do. Hounslow's contribution to tackling healthy weight is met by a wide range of action, including lifestyle interventions, very brief advice, food policy, and health promotion. But further action is always necessary and is done as follows. First, we have to understand that there's a very busy social media atmosphere out there, which means it's quite challenging sometimes to be able to cut through that and communicate with our parents and families. However, a number of channels have been identified and will be pursued this year with vigour. This includes, together with working with children's centres, family hubs and childminders, and the themes we intend to include action on around there and conversation around there is promoting a culturally relevant information and advice for parents on introducing first foods, a healthy diet in pregnancy, and routines for toddlers too. Focus on the life course approach is key, and as was mentioned earlier on, we'll support healthy maternal weight, and forthcoming collaboration opportunities will be established among maternity and health visiting family hubs and that INT project, as was mentioned earlier. The working groups which will be established, which I alluded to, will focus on childhood nutrition and obesity, taking best practice from the work achieved through the infant feeding group to date. There will enjoy it in consistency of messaging and among the frontline staff. I think it's important to recognise and to celebrate some great work undertaken by public health colleagues who provided the scaffolding for Hounslow's junk food and formula advertising ban, here delivering a forward whole systems approach to healthy weight, which also includes work around healthy schools, London, and alignment of work in oral health too, which we'll hear more later on. Thank you.
Thank you, Poppy. We know that in Hounslow we have one of the highest percentages of 5-year-olds with visually obvious tooth decay across London. In some areas of Hounslow, this is actually above 54%. Dental decay is actually more likely as well in children in deprived areas and in children that are from particular backgrounds, including Asian and Asian British backgrounds, and also in children with disabilities and with special needs. We know that our residents do consistently raise access to dentistry as a priority issue, and it's been identified as a North West London ICP issue and sort of core area of work. So we've worked with the primary care colleagues and the health equity teams to develop a plan of activity to improve outcomes for children and young people. We're continuing our work at the moment with family hubs, and with our primary schools, which has allowed us to reach more than 5,000 children to offer fluoride varnish to them, and uptake for that is increasing at this time, which is brilliant. We also know that that same oral health promotion team is exceeding their KPIs in supervised toothbrushing in our education settings, and they have an outreach programme held in community settings which are particular to our communities of need as well. So at the moment we're planning some visits to our local masjid, and we already have outreach going on at our local Gurdwara as well, which has been very effective, educating there on the importance of oral health, sensible and safe oral health behaviours, and sharing our Brushing for Life packs there. This year, Hounslow also spearheaded the establishment of the North West London CYP Oral Health Leads Group, which focuses on how we can share best practice, collaborate on new resources and approaches, and pinching with pride, as we'd call it, so sharing some of that really effective work. So through that, we've developed an approach for VCSE engagement and training, looking again at those target communities within each authority and aligning approaches. So we've started to commence the mapping of some VCSE groups through supportive organisations such as 3ST to bring together where we know that the best approaches work for the particular communities. We've also undertaken a review of a training package for these community tooth champions, and we're scoping some evaluation methodology for that to make sure that what we're actually doing is really effective. We are drafting as well some culturally competent low sugar communications for finalisation. And quite excitingly, we've had some funding that we bid for confirmed this week for a community co-production business case focused on outreach towards our SEND and COVID majority communities across Hounslow and also Brent. We're looking at some potential areas of work in the future, and we're hoping to develop a shared vision for oral health in the area, working from our existing needs assessments and strategic plans, looking at how we can develop some strengths-based conversations around oral health and how we can really create alignment there. And now we're on to school readiness. So we know that children in Hounslow do have lower than the rest of London in their rates of school readiness. And there has been a scrutiny committee in recent years that was focused on this challenge. So what we've done is we've looked at a bit of a renewed approach to school readiness. We're developing that at the moment. We want to make sure that our children are ready to learn at an early age through targeted information and workshops that have been informed from engagement that was previously undertaken by officers and from feedback from families that undertook the previous school readiness programme. So we've lately been working with early years advisors such as Lynn here, providers, school settings, SEND leads, children's centres and family hubs to get a bit of an understanding of how we can operationalise those findings and create communications, resources and eventually themed workshops that are going to be responsive to both families' needs and also to the requirements of our settings, to make sure that our little ones are really ready to thrive in education from an earlier point. We'll be looking to host sessions as part of a staged approach online and in person, and log information resources online. So independent settings and providers like our childminders and our local families can also return to and refer to that. That learning readiness approach is also a really great opportunity to reiterate and solidify a lot of public health messaging and aims. So those great habits that we can start early, like toothbrushing, having an early or set bedtime that's continually sort of enforced and managed, that really helps to have lasting impacts on a child's health and well-being. We're aiming to launch activity around that from April this year onwards, and we'll be looking at finalising and approving the content through the prenatal parenting and early child development working group there, and through our colleagues as well in education, in early years and in school improvement, to make sure everybody's very excited and agreed on what we're going to do there. So that's the wrap up of our journey element of this. And I'd just like to bring a bit of a good news story as well, which is a recent resurrection of a piece of work that's been really, really fabulous. We have relaunched our Healthy Schools London project, and we have a dedicated officer in place now for this, which is a programme that's through the GLA, which allows schools to complete a bronze self-audit of their current activity, a silver health improvement plan, and then a gold plan, which is where they implement that health improvement project within their school setting and they sustain it and report on the impacts of it over 6 months. As a result, we've had 3 schools reach bronze, 3 schools progress from bronze to silver, and 2 schools hit gold so far this academic year, which is a really significant uplift, and we're really quite proud of that piece of work. It's really important because it allows our education settings to lead sustainable action to improve health and wellbeing of students and promote healthy behaviours which continue back home and then into adulthood. We know that it's impactful. We see children that are at schools that have this happen become more physically active, increase their uptake of healthy school meals, and they therefore tend to experience improved behaviour and improved attendance. Our officer has a working group related to health and education settings that they manage, and they've also developed a really useful welcome pack around Healthy Schools London to support schools with achieving and undertaking the award. The aim is to have 10 schools moved all the way through to silver by the end of 2025, and a small number of those to hit gold so that they can act as case studies and really promote the effectiveness of the programme as we move forward and encourage the uptake there. I'll now hand over to David.
Thank you, Jen, and you'll be pleased to know that we are coming into our last piece of speech to you. So the colleagues have shared a wide range of partnership working that they've been undertaking to deliver the early years action as part of the health and wellbeing strategy. The services, the projects and the policy work will continue to be progressed throughout the year ahead, and during 25-26 under the following 2 priority areas. That is data and evidence, where we'll develop services and the improved health outcomes, and health literacy to develop family-led health improvement, where we'll be able to report back on progress of how we've achieved this, the following. So with regard to the data aspect, we will be targeting allocation of resources for early intervention work. I'll list out those to you here for clarity as a summary for you. That's healthy weight in pregnancy, and that's a prevention of excess weight and the complications for specific communities. Culturally appropriate dietary support for families. That is, for example, the confidence to introduce first foods well. Oral health and vaccination promotion to underserved communities. Second to last, developing healthier preschool settings to develop settings that are health promoting, and increase attendance of health visitor appointments. The empowering parents element of that through health literacy will include us using digital and health outreach to promote consistent and accessible messages. Perhaps these will be around diet and vaccine and being learning ready. Developing partnerships to help families understand and use and access health support in the best way and correctly. This might be through action around A&E and unplanned A&E attendance. And supporting child development to manage minor illness at home, using the health literature which we already have, but also we need refreshing, and also using the Healthier Together website, the Hounslow's first spot and place to go for health news and information. It's a significant task, no doubt, but with the wider team are already taking this in progress. Thank you for your time, and we're ready to take your questions.
Thank you very much. Thank you all of you for going through that very comprehensive report, actually very interesting, and obviously good to see some progress, but areas that keep continuing to so keep coming up again and again. I think I'll move on to questions. I'm just looking at time. Yes, yeah, we are okay for time. Peter, I know you had a question.
Thank you very much indeed. I had 2 questions of clarity, one on page 16 and one on page 29, and one comment I'd like to make on page 24. The question on page 16 is where we've got the ambers on the Healthy Child Programme, the Public Health Service. I'm not quite sure how far off the targets we are at the moment. We could be way off. We might be slightly off. Could you give us any clarity on that?
Thank you. Yes, the graph you've seen there is just giving you the rag colouring, but we are slightly off the expected area of progress there. But as I said, there is a service improvement plan currently in place already, which has identified the areas to develop to achieve that. Not least, that will be ensuring that families who are invited to attend those appointments do attend, and secondly, to make sure that there are enough appointments at the right places and spaces they feel comfortable to attend. So that's 2 particular areas of tackling that. Second to that is helping families utilise the video and see the service that they will seek to use is friendly and welcoming and something that they benefit from. Thank you.
Thank you, that's really helpful. If I can refer, please, to page 29. This talks about the Healthy School relaunch, etc., and the success we've had. We talk about 10 schools moving to silver. We got, if I remember rightly off the top of my head, 68 primary, 33 secondary in the borough. So how many schools are actually engaged in this very important initiative?
That's a really, really great question. So we've recently had a health in schools sort of workshop that was undertaken. We had 25 schools attend and hear more about healthy schools, and also around some of the health providers and opportunities that they have for engagement in their schools there. So we've got sort of 25 that are keen to engage with this at that point. We have our officer who has been working with an additional, I believe at the moment, 3 schools that they're bringing to bronze at this time. So I would say that at this time we're a little way off hitting that silver, but it is achievable, I would say, by the end of 2025 as we move into the next academic year, and we'll see how we grow from there.
Chair, thank you. That's useful because there's still quite a big gap for the number of schools we've got and the number of schools that could be involved in that programme. Chair, if you forgive me, my last final comment really is on your page 24. This is about your ASQ scores. And I know there's a real link to our next speaker, which is the North West London ICB strategy, which is, I think, on their papers, page 40. Critically, it's about the speech and language therapy services, not at this very early age, which is important, but ongoing. I chair a number of school exclusion appeal panels, and this constantly comes up. We're not getting mental health services quickly. We're not getting the assessment done quickly. And then when we do, we're not getting them into various services like speech and language and others. And therefore, there is a link, isn't there, between those two different strategies and how we might be able to move forward more collectively. Thank you, Chair.
Thank you, Peter. Yeah, points noted, really important. I think obviously we do have to do more work in this area, particularly around engaging with schools as well. I'm going to take a question next from Dr. Hilton.
Thanks, Councillor Bath. And I just wanted to make a few points, if I may, rather than a question specifically. Partly because I think it's reflective of the partnership between the community provider and the commissioners that I think we are as one in terms of the information that's presented. So I'm sitting here slightly sheepishly as the provider of some of these services, hearing the good things about them. So thank you. I wanted to acknowledge that West London Trust became responsible for the universal services just back in July, and we inherited a really positive, really excited group of staff and really good relationships with the council from the outgoing provider HRCH. As a trust, we monitor the performance of these services at board level, and we've been watching continuous month-by-month improvement on some of the key metrics, particularly the 14-day access target at board level, and also benchmarking ourselves with our partners within the North West London Community Collaborative, the other 2 trusts also providing universal children's services, to ensure that we're not an adverse outlier compared with other providers of universal children's services in our geography. I think we are slightly to pick up on the question that Peter made, and David answered it really already around some of the areas where there are ambers. There are plans that we are cited on as a board in terms of the performance improvement, and I won't go into the detail, but Shirin, the divisional manager, I know is watching on YouTube somewhere, and is has a whole plan in place around using social media, using additional clinic capacity, volunteer support, text reminders, and lots of other ideas around how we can improve the access targets for our 1- and 2-year developmental reviews, and was very keen to ensure that that we are making every contact count to promote vaccine uptake and to record vaccine status. There's a lot of integrated working going on, and the Family Hubs work is one example of that, but also other work that we do with the other universal interventions around speech and language therapy and OT in the Family Hubs. But also as a trust, I've been really energized by the feedback from the teams themselves around the relationships that they already have around other services that we have. So we also have mental health support workers in every school in Hounslow, and they have each other on speed dial and know how to make the most of the shared resources that we have. I was very pleased that you mentioned the UNICEF feedback, which again has been shared with the board in its informal status at this stage, but they interviewed 65 families to hear about their experience of the health visiting services in Hounslow. And the themes were universally positive from those interviews, which is a credit to the team. And finally, I just wanted to make one last comment, reflecting the partnership work that's essential really between commissioner and provider of these services in working within the resources that are available to us. And it's relevant as we do compare ourselves with our neighbours that there is a significant differential in the public health grant that is available for the kind of historical allocation calculations. And by my back of a fag packet calculations suggest to me that the amount that's available per child in Hounslow is about £200, £230 per child. And that compares to £930 per child in Westminster. So as we think about, a levelling up agenda, there's some way to go for our local residents.
Yeah, thank you for sharing that with us. Yes, I'm alarmed at that figure. Yes, Kelly, are you going to?
Yeah, thank you for pointing that out, Chris. It is fair to say that Westminster does have the highest public health grant in northwest London, and does have considerably less children than actually half the resident child population. So we get 50% of the grant. We get 18.2 million. And Westminster get over 35 million. And there is a disparity between central London because the cost of service provision is higher, but it also comes with, often it can be easier to get recruit into central London services because of the use of public transport and the ability to move around easily in that area. That said, there was a benchmarking that carried out by OHID. Results came out the end of 2024, with 32 boroughs participating in a review of their 0 to 19 services, looking at health visiting and school nursing. And actually, I think apart from one borough, and we can't identify which borough that was because it was all confidential, who seemed to buck the trend. All the other boroughs seem to be performing in certain areas very well, in other areas less well. But it was quite clear that all of the boroughs had issues with capacity and availability of a health visitor and school nurse workforce. And there was some direction to commissioners about what to ask your provider, which I think for some of those areas were things that we were already sort of dealing with and supporting as part of that re-procurement. But certainly the West London Trust 0 to 19 services have performed very, very well in line with the funding that we give, which is to a lesser amount than other areas for obvious reasons.
Okay. Thank you. It's good to hear that we are doing well given the funding. Just to pick up on that, is there anything that we are doing in terms of making that case?
Until the allocation algorithm and the criteria upon which the grant is assigned, that won't change. It's I think, and I say it out loud, I think it's still based on the number of older people over the age of 75 and the levels of deprivation in a borough. I think that was the past criteria. I haven't seen a criteria change, and certainly proportion of grant allocations appear to be somewhat similar year on year. It normally increases by a relatively small amount per year in comparison to the cost of services. So as a board, you should be aware that as we move forward, the cost of service provision is increasing at quite a significantly higher proportion than the uplift to the public health grant, which does mean at certain points we have to make decisions about what we maintain, because there are mandated services that we have to provide, which includes the 0 to 19. But as those costs go up and the proportion of the grant is spent on those mandated elements, that discretionary area, like the contracting of oral health promotion, considering, as we've pointed out, that children in northwest London have the poorest teeth or the most decayed teeth of anywhere in London. Those are the discretionary areas that we might have to review funding for if the grant continues to be at this level.
Thank you for sharing that with us, Kelly. Has anybody got any questions? Stephen?
Again, it's not a question, it's probably a bit of reflection, observation. So I think thanks to colleagues for taking us through this. It's always cheering to hear the good stuff. And it's interesting, earlier on today I was at Children's Model Care Programme Board talking about what's the impact of our family hubs. We know what the impact is, we've got evidence to suggest it, so it makes all of that work worthwhile. I mean, I think the reflection here, and it is about the timing that we find ourselves in just now, much of this, regrettably, has a natural repeating element to it. It's multi-generational, it's embedded, it's systemic, and it's of great concern. And I think probably as a local authority and our partners, we need to continue to put a significant amount of emphasis and focus on childhood development in terms of the long-lasting impacts it has. We've just heard from colleagues here about, low birth weight, what that means for you as you progress into your adulthood and your general well-being. Readiness for school, social readiness for school, not about your ability to learn, but your ability to participate. The impacts of that has, we know from our schools that the first year for many children is lost in terms of just preparing them to learn. And that's a year they lose that fundamentally most of them do make up. But what we see, whilst we have a good education system in Hounslow, is we don't fly and we don't aspire. And if we were to start our children at school ready to learn, we might in a generation see the young people of Hounslow aspiring in greater numbers. So I think for all the things that we talk about as a local authority in terms of our corporate plan and our objectives, the pre-birth to the end of Key Stage 1, age 7, becomes more and more an area for me that we need to pay far more attention to, because if not, the next generation and the generation after them, 20 years down the line, will be in no better position than the generation we're talking about now. So whilst we are service-wise making improvements, there's a bit of me says we need a collective heft, and I really don't know what that heft is because I haven't got all the solutions, but we need to pay this more attention, because if not, by the time I retire and by the time that Chris retires and all of us retire and the next generation come in, they will be sitting in this room having exactly the same conversation. So we need to turn our attention to this, because if we break this, we break systemic disadvantage. And that's why, for me, I get excited by it, but I also get sometimes a little bit down by it, because we're doing really good stuff, but we need to, I think, find a heft mechanism to move it, because we're not pushing it hard enough to make the difference. And it might be, dare I say, given our current financing and resourcing, that we need to make this a priority over some other things, because it might actually stop some of the other things down the line becoming as big a problem as they are at the present time. So I think from a health and wellbeing board and a health wellbeing strategy bit and a corporate and partnership bit, I think we need to keep revisiting this and we need to talk about it more, because it's just fundamental.
Yeah, I absolutely agree with what you said, and share your frustrations, because I mean, Sue and I have been, Councillor Sampson and I have been councillors for quite a long, and I think some of these topics we have been discussing in various forums, haven't we? Weight, school readiness, oral health, all of these we've discussed, many times. Just before I get a question from Sue, I know you're waiting. I just had a question, really reflecting on what Stephen has said. Given some of these issues that keep coming up again and again, is this a particular cohort that has all of these, or for example, unhealthy weight, poor oral health, high attendance and is it a particular cohort? Because because I know you've got lots of different programs and targeted work in place, but I just wonder if it's the same group of people that are presenting different kinds of problems, if you know what I. So it's easy to get a handle on what's going on, because I struggle to understand the complete story and why, why we keep seeing these problems again and again.
I think you've highlighted a point there neatly, which described what I said on the first slide, which is that income deprivation and living in poverty is the key indicator of poorer health outcomes. So it can be that some families in that situation do have multiple disadvantages in health, as being described here. And I think that the approach we seek to take is to identify that, as was mentioned, use our data to really laser in on where we can direct messaging, services and connection between those residents and the services that we provide, as well as self-help and the plethora of information that's also out there from a bona fide perspective on the internet. So recognising that, connecting, communicating and helping them to access those great spaces that we have, such as family hubs, children's centres, to kind of feel that connection and community. And that leads me on to the best way to tackle that is to engage with the community, helping communities be strong together. And there's obviously lots of council effort around developing community hubs as well for that.
Yeah, I mean, the community hubs obviously play a really important role, but I wanted to sort of bit of a caveat here. We can't just rely on the community hubs to do everything as well. And because I'm acutely aware that there may be lots of people who don't actually attend community hubs. So it's about getting out to people that aren't necessarily going to. So just have to be mindful of that as well. Okay, I'm going to move on to question. I've got Sue and then Stephen, yeah? Oh, you wanted to follow? Yeah.
So I think one of the things we need to, be a bit braver about, because we can see this through a service lens, and we should absolutely, because we are responsible for delivering services. But if I go to, what I can see in children's social care, which is the experience of what we just have to term is poor quality parenting. And I can't get away from that. It's not neglectful. It's just not a good experience of parenting. And that is multi-generational. If you didn't have a good experience of parenting yourself, you're not equipped to understand what being a good parent is. So there's a bit about knowledge as power in this. If people have information and knowledge and experience, they can, with some of that heft, move themselves up by the fact that experience is different. And it's not to say that everyone who had a bad experience of their own growing up in parenting will automatically replicate that, but we know that there is a direct correlation between the experience people have of their own growing up in parenting and how they parent, and their knowledge base to be able to be a good parent, and their confidence. So there is a little bit about, there are some very simple solutions. Information is a simple solution. It's very cost effective in terms of how you get that out. It's why every opportunity I have, I will talk about the 50 things to do before you're 5. And I will say to you as elected members, if I get your phone and find out you haven't downloaded the app and everybody isn't using it when you're in your surgeries, to say to parents, that's what we should be doing, because the 50 things to do before you're 5 have a multitude of benefits, but it's a really cheap thing to do. It's a really good thing to do. So I think what we've got to get better at is what's service, what's information, and what's a community dialogue about how we can make this work better. And I think we've got to be a bit braver in saying some of it is having to have an open conversation with some communities in some parts of our borough about, do you understand what good parenting is? Do you have access to that information? How do we help you have it? And then where the services come in, but it's not always a service solution, I think, first. It's sometimes a conversation that needs to be had before we say, well, actually, here's the pathway to the service that can help you. But that's more difficult in terms of how people react to it. Because the service that comes is my service in terms of children's social care. I don't want any child to be a child in need. There's a legal definition, and we've got dozens of them. Because, and a lot of that is just low-level parental support. It's not actually child protection. It's about verging on neglectful, verging on not knowing, verging on not actually being able to promote the welfare of their own child and to adhere to that. So we need to be able to use that information flow, I think, sometimes a bit better. But it's not always a service issue that it becomes.
Yeah, thank you, Stephen. I agree. And some of the things are very simple. 50 things to do before you're 5. I think that's a fantastic campaign, and we talked about it before, and more than happy to support that. And we, I think, yeah. Okay, Councillor Sampson.
It was just off the back of what Kelly said and Stephen touched upon as well. Yes, what you said, Lily, we have been councillors for a long time, and some of these subjects are, repeatedly sort of ongoing. But I think we do now that we've, I know it's slightly a bit of a political issue, but now that we've had that change in government, I do think we need to bring this to the forefront of that, of the health minister. So maybe a letter from the borough would start that ball rolling.
I mean, we talked about the resources and capacity and finances earlier on, so this is something we could probably put in together. Yeah. We can have a chat about that and do that if the board is happy with that.
And the 50 things before you're 5, Hounslow Matters, that's a brilliant campaign.
Yeah, that's a really good. I'm assuming we're already sort of behind advertising that.
Well, let's do it. Let's do it.
I would have a feature on every one of the 50 every week, and why it's important and why now we're to try it now. I would just keep pushing it, and in your surgeries and in area forums, we just need to keep pushing that knowledge, because that knowledge helps babies develop, and it gets over that school readiness stuff. That's why it's so important, and that's the easiest way to do it.
I mean, we're more than happy for you to come to area forums, and that's absolutely. Well, it's just having the information available, isn't it? As you said, it's very simple. Yeah, exactly. Not that many. Yeah, but no.
Yeah. What Councillor Sam said, I think it is timely, because beyond the Department of Health and Social Care, from the Department of Education and the government's drive with the children's wellbeing in schools bill, we are getting a constant stream of stuff at the moment from the Department for Education about the shift to prevention, the shift to early intervention, the money that's coming to flow with that. There are absolute overlaps and links to the public health agenda, to the education agenda, and to the health agenda, though it's a bit more quiet on that. So now is the time, I think, because government is trying to formulate its methodology there. So I think we have an ability here to say, this is what we're doing locally, but this is what would help. And I think we might be able to use this time to do something. So I think it's maybe a conversation between myself and Kelly about what we, with comms, put together, potentially from yourself and Councillor Chowdhury, about what are we wanting to say here.
Thank you. I think we're in agreement with that. So that could, if we can take that away as an action. Thank you very much. Any other questions or comments? I don't think we have. Oh, yeah.
Just coming off the back of the advertisement for the 50, Hounslow Housing does its own publication. And seeing I'm on this board, that it can have a page there and promote it, that as well. And that goes through every council property in the borough.
And as an action, thank you. How frequent is that?
Quarterly.
Okay, brilliant. Okay, thank you. Okay, can I just thank you all for sharing all of that information with us? Obviously, some really good areas where we've seen progress, but we obviously know you know all the areas that we've got to see sort of more work done in. But thank you very much for coming, and I'm happy for you to stay if you want to till the end of the meeting or whenever. But equally, I'm happy for you to leave as well. Didn't want you to think you have to stay. Okay. All right. Yeah. Thank you. Okay, so if we now move on to agenda item 4, and we've actually got Toby Lambert here from NHS North West London. And Toby, you're going to present the forward plan, which is the North West London forward plan. We've given you around 20 minutes, so obviously key highlights and maybe a focus on Hounslow, if that's okay. Thank you very much. Yeah.
So thank you, Chair, and so thank you for inviting me here this afternoon. I was going to give you a relatively brief sort of verbal introduction to it rather than try and rise to the challenge of presenting 90 slides, which I suspect is not what we want at this time and sort of the afternoon. So I'm going to do a sort of number of things. I'm going to give a bit of an introduction to what it is and sort of why it's important, and sort of remind you of the Health and Wellbeing Board statutory duty in relation to the sort of the joint forward plan, and talk a bit through how we've developed it sort of this year, sort of the major themes in it, and then sort of essentially sort of leave it then open for you to sort of ask me questions or make suggestions for improvement sort of in that sort of joint forward plan. So, so the joint forward plan sort of follows on from North West London's health and care strategy. The health and care strategy we completed in November 2023, and what the joint forward plan does is lay out how the NHS, so that's the ICB and the our provider trusts, intend to implement their part of the strategy. And it's important to note that joint in this context means joint between the NHS bodies. It does not mean joint in the same sense as a joint strategic needs assessment or joint health and wellbeing strategy. I might wish it did, but that's not what the legislation says. It says it's on the NHS side. We're required to do one every year, and we're required to cover 5 years every time we do it. Again, that seems a little bit bizarre to me, but that's what the legislation says. So you will get to see me every year coming to talk about a 5-year plan. Because it's a sort of 5-year plan and we have to do it every year, and the first one we did last year, the refresh this year has been relatively sort of light touch, because it doesn't seem terribly sensible to completely rewrite a 5-year plan every single year. I do have to note that I didn't come and see you about last year's sort of 5-year plan because it handily coincided with the mayoral period of purdah, followed by the general election sort of period of purdah. So that is sort of unfortunate, but that is what it was. So, and that's why this is the first time sort of this has come to you. Your statutory duty is to opine, to provide an opinion to the Integrated Care Board on whether you feel this plan adequately meets the needs of the residents of Hounslow, particularly as expressed through the Joint Strategic Needs Assessment and the Joint Health and Wellbeing Strategy. So that's the bit you have to do. Obviously, I am very welcome to any other sort of positive suggestions, improvements, and so on the plan, but that is the statutory bit. So this year, we tried to achieve sort of 3 or 4 things slightly differently from sort of the previous plan. So one was to be tighter on our prioritisation within it. We have a sort of general belief that we will get more done if we concentrate on, say, 3 things in year 1, 3 things in year 2, 3 things in year 3, than trying to do 9 things at once and spreading our sort of resource, our collective resource a bit thinly. So that does mean that the meat of the plan is really in the decision behind the plan in what happens in year 1, what happens in year 2, what happens in year 3, as opposed to the sort of the headline sort of priorities. That said, we do have sort of 9 sort of headline priorities. They are the same as the priorities sort of last year. They are sort of in the plan on about sort of page sort of 5 or 6. We have slightly reordered them sort of this year, but they're not sort of fun. They are the same. They remain. I'm trying to find them in my copy of the document. Here we go. So establishing integrated neighbourhood teams with primary care at their heart, reducing inequalities and improving the health outcomes through population health management, optimising the flow of patients through our system, which is sort of right care, right place, sort of right time. So embedding, so accessing consistent high quality community services, and in particular doing that through the maximising our productivity, improving children and young people's mental health and community care, which has quite a strong link to what you've just been discussing, improving sort of mental health services, particularly in the community and for sort of people in crisis, transforming maternity care, increasing the cancer detection rates, and transforming the way in which sort of planned care works. So those are the 9 headline themes. The bulk of the document then goes into talking about those themes in sort of more detail and the sort of the progression of our of the evolution of each of those. There are those, or broadly, 3 cross-cutting themes across each of those 9 priorities. and that is in years, well, was years 1 and 2, but now year 1, because we've moved on a year, is sort of embedding what we call a sort of core common offer across sort of Northwest London. So that's ensuring that we have a consistent set of services available in all of our boroughs. I could give you sort of plenty of examples of where our predecessor CCGs have commissioned a different set of services depending on the borough. And obviously that, in some ways, that was the point of CCGs, to be able to do that sort of local, but it does leave us with a position where sort of one borough will have a paediatric incontinence service, but the neighbouring borough won't. And while so I don't think that all of our services should be uniform across Northwest London, I do think that the consistent set of core, there should be a consistent set of core services. So that is sort of the first sort of theme. And we do that, given there's no, well, I don't think that Rachel Reeves is going to give us a bunch of extra money to do it, by continuing to push on the productivity, because that's where the money is to do that is going to come from. And the second theme, which is then more in sort of years 2 and 3, is how, as we do that, do we better tailor that core common offer to the needs of our different sort of communities in our different boroughs. So consistent is fine, but it has to then be tailored. And tier 2 and 3 will go into that. And then 4 and 5 is more about how we do the bespoke services for sort of particular sort of populations. So there is a limit to how far we can tailor the core offer. There will always be particular populations for whom, no matter how far you tailor it, sort of that will not work. And that's where the stress then sort of falls in years 4 and 5. So we could pull on sort of a number of examples. So sort of rough sleepers might be one. We have the largest travelling community in Europe in sort of Ealing, and particularly for sort of those closer to Heathrow Airport, sort of refugee and asylum seeker sort of populations, which I know you're working on, but how do we sort of deepen that? So those are the sort of the 3 sort of common themes which sort of run through sort of consistently. There is, so that applies to sort of all of our areas. There is a particular sort of page in there on how that sort of then applies to sort of Hounslow. Actually 2 pages at slides. I've got it printed out so small I can't even read it. But somewhere around sort of 51, 52. Sorry? 85. Thank you. You've got a larger version. In my attempt to save paper, I've printed it out on 4 slides to a page, which means the numbers are now far too small to actually read. So there are sort of those 2 pages, and so they've been developed by the sort of the Hounslow sort of borough-based partnership. So Martin in particular is probably even better placed to speak to the sort of the Hounslow priorities than I could sort of ever sort of profess to be. But the 6 particular areas they pulled out: the healthcare integration, frailty programme, prevention of health inequalities, community mental health, children with certain disabilities and complex needs, and those integrated neighbourhood teams. Now there is a fair read across from those 6 to the 9 which I have sort of laid out, and the trick we have to sort of bring off is how we do the to get the benefits of the scale for doing things once, when we can sort of manage to do them once, as we don't have enough resource to do everything 8 times over. And I would say that even though each of our boroughs are obviously unique, there is quite a lot of commonality in the issues which they are facing, and we probably don't need 8 entirely bespoke and separate solutions, but ensuring that those solutions are then able to be tailored to the different needs of the population, slightly less at sort of the Hounslow borough level, but you all know that your communities are quite different in different parts of Hounslow. So how we sort of do that, ensure that those are able to be tailored for those. So we are now in the stage of sort of bringing this to each of our sort of health and wellbeing boards. It's also up on our website for sort of public comment. We are doing that over the next sort of couple of months. We will then sort of refine in the light of sort of any comments and suggestions for improvements we have received from yourselves, any other stakeholders, or our public. Those who are avid NHS watchers, which is probably a couple of people in this room, but not all, will know that we get an annual gift of operating guidance from NHS England, which basically says that this is what you must do over the next year. And it hasn't actually turned up yet this year. It normally turns up just before Christmas. So we'll also have to build that in sort of when it appears, then the requirement that we need to publish the completed version by the 31st of March, which again is handily in the primary legislation. Okay, so what I would like from you is primarily suggestions for improvement. Now, how can we make this better? But then I do have to also ask for your opinion on whether it does meet the needs of the population or not.
Well, thank you, Toby. Thank you for presenting that. I'm just going to bring in Kelly, and then I think there's a question from Peter as well. But this is for comment and obviously for us to sort of give your comments now before the 31st of March.
Thanks, Toby. We can aggregate the comments on behalf of us as the Health and Wellbeing Board. Yeah, perfect, because I think we did that the last time. No, absolutely.
Yeah.
And I think some of it was that there were some timing issues in terms of when it would need to be published. So I've got a few things just to sort of general comments. One, I think the JSNA work that Rachel, I can't remember Rachel's surname, did was wonderful. And she did that consistently for all 8 boroughs. And actually that really set out that there was quite significant sort of similarities with different areas, and I think that as a kind of setting that and working with the boroughs as your team and North West London ICB have in many of these areas has really benefited the ability to be able to make sure that our comments are properly reflected in much of this. What I would say though, and always, I'm not going to say but, comma, I do think that what your comment right at the beginning about this is about how the NHS works and how the NHS delivers. If you kind of remember that infographic that we always have, clinical services at best achieve 20% of health in a population. It's councils 60%, the wider determinants of health, the environment that people live in, and the rest is about people's behaviour. And obviously, if you put a Venn diagram together, there's quite significant crossover. So in order to achieve health, and I'll say this as a public health director, is that you can't be healthy unless you've got all of the kind of infrastructure that the council. And so working with councils to make sure that we're properly aligned to delivering those wider determinants in health is really, really key. So that kind of leads me on to how do we make prevention, because we've got prevention in here. How do we properly invest in prevention? Because we talked about the public health grant, and the public health grant should not be the sole funder of prevention. Question one, how do we make prevention really a sort of and delivering upstream activity really core when we're responding to significant demand? That's question one. Question two is maternity service provision in terms of variation in quality across North West London. Just feels like if we want our children to get the healthiest start in life, some of our service provision and the sort of lack of capacity and some of the outcomes for children during that pre-pregnancy, which is where public health has a big place to play, and how we link with maternity services and that 0 to 19 service needs to be much more, that partnership and that working arrangement needs to be significantly improved. And the third area is, and I think I flagged this at the last year's one, is I'm not sure how reflective on end-of-life care this document is. I'm not sure, I couldn't see it in the slides that I kind of reviewed. I couldn't see end-of-life care featured, particularly around preferred place of death and how we support people to die at home or in a homely environment, rather than sort of lifting and shifting and as a kind of an emergency into hospital. So I'd like to see end-of-life care really feature more, because I think this is an area that we don't do well in North. There is some variation in North West London. We don't do well as a borough, and actually collectively we could enable people to die well at home if we had the infrastructure to support that. Thank you very much. Happy. I will put together a comments on behalf of all of us, but those are the key things that I think I'd like to emphasise and I'd like to flag as I think a little bit of a gap.
Thank you, Kelly. Anybody else? Yeah, Peter, and then I'll bring in Martin.
Toby, thank you ever so much for the document. There's obviously lots of questions, and this wouldn't be the appropriate place to get into the detail, but if I could focus on a couple of things which I think are quite key. You have mentioned a number of times, and it's in your document a number of times, core common offer, and separately but linked, an operating model, but there's no detail, and it's been talked about for quite some time. There's no detail on what a core common offer is, or what an operating model is that you may be imposing or pushing or developing across Northwest London. And the devil is in the detail, because whatever the borough is, it must mean logically that something has to stop, something may be gained, because there may be a service that you want to bring in a core common offer that we don't have, but it might be that we're doing something that others don't have, and we have to reduce to provide this core common thing that has no detail on it. And I accept the fact that this is a strategy, but it's really important to understand as a borough, and the board need to understand, what is this core common offer going to be, because it's going to impact our residents and our services. And what is this operating model? And I know there's been lots of discussion in the background, but it is quite key, I think, now, because I understand you've got to merge these services and have a common offer, but we got to get into the detail of what that actually means, and therefore how we develop our own strategies and services to respond to it. I would also like to support what Kelly has just explained, especially the end of life. It's not mentioned in here. We're aware of Northwest London and the huge project that's been going on for over 3 years, but that is about a very small proportion of specialised palliative care for the community, but it's a very, very small element of palliative care. And we are doing great work here in Hounslow around other areas of community palliative care. What you do is important. What Meadow House does is important, but end-of-life care is a big issue that we really ought to get to grips on, knowing what the bill has been discussed in Parliament, knowing the demand that we've got. We do need to wrap this into the more common operating model and the more common core offer that we're going to be offering our residents.
Would you like to respond to that, Toby, before I take another question?
Let me, if I can sort of respond to both. So the sort of prevention, how do we invest more in sort of upstream? Yes, sort of absolutely. I have to say, there is a part of me that says sort of the NHS has been saying that since at least 1948. So the core bit is sort of what is different sort of this time. And part of it, I think, is sort of commitment, and sort of part of it is that our data is better than it's ever been before. So we are more able to target the prevention, and hence we're better able to show a better return on it than we've been sort of able to do before. So, but there's quite a lot to still sort of work through, and so how we bring across so those 3 shifts, which are sort of incoming government has sort of laid out on the treatment to prevention, sort of hospital to community, and from sort of analog to digital, and particularly how do we do all of that equitably. The sort of maternity provision, yeah, absolutely. We are, as happens, sort of scoping up a sort of piece of work on sort of maternity and sort of neonatal strategy sort of at the moment. Sorry? Yeah, Vicky Cochrane, yeah. Yeah, absolutely. So I have a first draft of a scope, which Vicky sent me sort of yesterday morning. So we're in the process of sort of refining that. And I'm more than happy to involve you in that, Kelly, and indeed anybody else whom you might suggest sort of in Hounslow to ensure that we properly capture the issues which you're facing, indeed all of our boroughs are facing, so that the strategy work stands a better chance of being able to answer them, so we know if we're clear on to what they are. So end of life, yeah, okay, so you both brought that one up. I will sort of go back and see what more we can sort of put in on that. As you're right, we're doing a piece of work on specialist palliative care, but it is not the entirety of sort of end of life care by sort of any means. sort of core common offer. So we do have sort of laid out what we think is the core common offer, which we're trying to get in for 25-26, and then how that then might expand for 26-27 and so on. I'm more than happy to sort of share what we think sort of that is. We have an underlying hypothesis at the moment, which still needs sort of proper validation, that the degree of sort of variation in what we see in the productivity of the services will go quite a long way to being able to bring in that core common offer without needing to sort of reduce services in sort of certain places to sort of make that work. Now, no, as I say, it's a strong hypothesis. I can't sort of hand on the heart sort of say it's true, but we stand a far better chance of being able to sort of level up to a consistently high sort of core common offer rather than level to the middle if we're able to really push sort of that productivity. There's as much as I might wish that there is a lovely pot of money heading in our direction. So one, I don't believe it, and two, if it did turn up, I would be suggesting to our so people in sort of Wellington House and Department of Health and Social Care and so on, that there are probably sort of worthier recipients of it than sort of the NHS at the moment. As tight as it might be on our side, and it's been far tighter on the sort of local authority side over the last number of years, and quite a number of the issues we face are probably better solved by investment in areas which our local authority colleagues are responsible for than for areas which we are. Operating model, there's a document on our website which sort of lays out what we mean by operating model, which I'm happy to circulate. But in essence, it's how the ICB sort of internal sort of mechanics work, sort of role of boroughs versus sort of role of the centre, and how we work with our sort of other sort of NHS partners. So it is a little bit of a dry document. Shall I put it that way? So nonetheless important for being dry, but I'm quite more than happy to circulate if you would sort of like to see it. Yeah, it is in a constant sort of update as we sort of learn and sort of refine how we work.
Thank you, Toby. Martin.
Thanks, Toby. So I hear loud and clear this is a statutory duty that we have we can comment, but it's a forward plan between the health partners and the ICB. But that's a statutory duty. Doesn't mean we could widen that and involve local government and have a one system local plan. And if we did that, the financial challenges of local government will be in there. Everything you say, if we did it really well, we'd do it much better together. And as you say, you're going to come back here for the next 3 years. So has the ICB thought about how it could engage local government more in this, so it's a more integrated forward plan, shares the whole problem, the whole solution? And if you asked the other 8 health and wellbeing boards if they wanted to contribute to it more next year, would they be willing? Is there an opportunity that we could take forward next year?
So the answer to that is sort of yes and yes. So we didn't do it as well as we would have liked to sort of the first time round. For this time round, we've done a bit better at inviting our sort of local authority colleagues to a number of the key meetings as we have been sort of developing it. That still isn't quite in the space of full sort of engagement. So yeah, that's sort of, yes, we thought about it. We do then need to sort of come back at some point, presumably over the summer, once we complete this cycle, with sort of how we think that might be improved, or indeed sort of solicit ideas from all of you on how you think sort of that might be improved.
Thank you. Kelly.
Just paraphrasing one of the North West London paediatricians, I think within the gift of the forward plan and the ability of the ICB to deliver significant improvements across NHS services, wouldn't it be wonderful if we could level up to the level of the best in North West London as a starting point? Because just think what that could achieve considering the variation that we currently have, and then start thinking about levelling up to the best in London. Just think that we should be really ambitious for that.
Yeah. Agree. Stephen?
So I think because Toby's picked up on it, I think it just reflects the conversation. So, priority 5, which is limited, and I'm going to be cautious here because our local plan is even more limited, improve children and young people's mental health and community care. I think, and I get why that is the focus, but I think given it's a 5-year plan, when you come back next year, I think we should all be talking about what we're talking about, which is general children's well-being. It just shouldn't be the mental health bit, but I understand why that is a priority at the moment, because in our local provision, we've even narrowed it down. I wonder why, to SEND and complex and disability, but I think we post this year want to shift that onto the wider children's well-being bit. So I think it's how we replicate that. And I think probably for me, again, I'll take it, as you say, Toby, because this is a health document. Priority 1 round about integrated neighbourhood teams. I'm a fully paid up member to the INT cult. I will declare that now. I will wear whatever the cult requires me to get there. And I understand how it's worded here with, and don't take this as the wrong approach, Amit, primary care at the centre. From a NHS perspective, I get it. But to pick up what Kelly was saying, the model of INT to deal particularly with the cohort I get really interested in is the frailty cohort, who are drowning us collectively. It cannot just be primary care at the heart of it. It has to be the individual at the heart of it, because more and more, much of what we're trying to tackle with them about how they flow around the system is not clinical. So I think somehow we need to be able to find a track which it isn't diminishing the role of Amit and his colleagues, but isn't pushing it all on them, and actually recognizing that many things that we see with that cohort are just practical data. I mean, if I was to sit here and just recount some of the conversations I've had this afternoon about some complex patients at West Mids, there would be very little clinical stuff, but they are repeat visitors to West Mids in terms of their complexity is who's got their keys, who's got their money, whether the landlord has actually locked the property up and nobody knows who the landlord is. And yet they're sitting in West Mids because we can't collectively do much else with them at the present time. So I think the INT bit, I get here why is primary care at the heart, but I think as a system, we need to shift away from it being the person at the heart of the INT. And I think listening to what was on the radio this morning in Public Accounts Committee about the challenge to the NHS is throw all the standard operating procedures and all the clinical pathways off the table when we talk about INTs and start from the person backwards. And not start with the vet, because I was a bit concerned. I think I was the only local authority person that went to that INT workshop in Brent Civic Centre, much to do because it was only a 3-minute walk down from home to get there. But I was the only local authority person there. And what worried me was a great emphasis there on the vertical integration between primary care and specialists in the hospital being the INT model. And I was about to revoke my cult membership that day, because I thought, if that's what it is, I don't have a role here. What was interesting is one of the presenters there said, the key to INT is social care, and then didn't say anything else about social care. And I sat there waiting for her to get to the punchline, but we never got there. It was all the vertical integration with the specialist pathway into the acute and the paediatricians. So I think we do need to collectively get our heads around what this means as a wider system, but absolutely get the whole clinical bit in the middle in terms of the NHS. I'll get off my INT soapbox now.
You want a t-shirt? Okay. Peter, did you have your hand up?
Sorry, I didn't want to stop Toby responding, but I was just going to follow on the INT, that if we look at your plan, Toby, it's great, but it's exactly what Stephen articulates. It's the primary care and to the acute, trying to sort some of those issues out. But if you look at what we're trying to do in Hounslow, we're looking at the population health data, what the real problems are. And in my particular area, it's about depression, etc. In other areas, it's around frailty. We're trying to hit the problems of our populations, and we're struggling to get that INT really working effectively. But your plan has got completely different objectives. So I think this INT is great, but we haven't got this sorted out at all. We are looking at this from different points of view, understandably. I've been in partnership since the 80s. We were trying to do this in the 80s and we didn't crack it then. We didn't do it in the 90s and the noughts, and this isn't going to quite crack it unless we, really get that joined upness working. And it's hard, but I think it's a great time to really try and crack this.
Thank you. So I'm kind of wrap this up now. And I think obviously you've heard quite a lot, but I think we need to formalize it, and so that you have our comments. Is that okay if we kind of put that as an action? Because obviously I don't want to lose what we've said. Is that okay with you? Did you want to make one final comment, Toby, before we move on? Or
What I was going to say is I absolutely agree with Stephen and Peter on the sort of the joined upness sort of point. We do, however, have a spectrum of local authority views, from the fully paid up members of the cult, which are sort of Hounslow and sort of Brent are sort of firmly in, through to the INTs that absolutely nothing to do with us. If you write anything about local authorities doing something with INTs in your paper, then we will say no to the entire thing. So there is a little bit of sort of triangulation going on in sort of what is written here. Yep.
well, thank you very much for coming along. I think we've had a good discussion, and obviously there is some common understanding, but obviously you're also aware of some of the challenges and some of the comments that we've made today. Okay, I'm going to move on just because of time, and we're moving on to the next item on the agenda, which is actually Martin. You're going to give you've got about 10 minutes to give us a very quick update on the Better Care Fund, which is for us to sort of sign off and just assure that we're happy with it. Yeah.
Yes, thanks very much, Chair. I'm lucky enough to bring a Better Care Fund to this board every meeting, I think. So it's my purpose. So last time we brought the planning document, this time we bring the quarter 2 performance, which is also including the quarter 1 performance. In your pack, there are 2 things. The section 75, which explains the whole of the Better Care Fund, which I hope you've all read again. And then the second document is a planning document, which is a lot of data, very hard to see, but confirms that we are delivering within our Better Care Fund. We shared this with Councillor Bath as the chair of the Health and Wellbeing Board in October, because it needed signed off in October. So we're just bringing that here for formal approval. The purpose of the report is to confirm status of continued compliance against the requirements of the Better Care Fund, provide an update on spend and activity against the additional discharge fund, and to provide actual activity for demand and capacity reporting and refreshed narratives. So that is all within the report. None of this is new to you as a board. Stephen and I and Mark Jarvis, who is a member of the ICB team, have oversight of the Better Care Fund, and we have regular meetings to ensure performance and spend is in line. So we have no concerns to raise. If you have any questions, feel free, but otherwise we just want you to approve Councillor Bath signing off of this.
I'm obviously aware of this. Any other questions that anybody has at all, or any concerns? No? Okay, then we sort of formally sign it off. Yeah, thank you. Thank you, Martin. Can we then move on to agenda item 6, which is a standing agenda item we have from Kelly on the Health and Wellbeing Strategy update. Thank you, Kelly.
Colleagues will find the report as per you get every meeting in the pack. It is RAG rated as per usual based on the progress that the report is, that the projects are achieving against what they set out over a 3-year period to achieve. There is a little bit of variation in this report because some of the areas there are 3 RAG rated areas, I should say. I think there's been a little bit of being hard on yourself in terms of the first RAG rated red area, which has moved from amber to red, which is stop smoking referrals between West Middlesex Maternity Unit and Healthy Hounslow. I don't think it's necessarily red. I think the process, the referral pathways haven't been sufficiently robust, but there is an on-site stop smoking service that is actually supporting women. And as you've heard from public health colleagues today, the level of stop smoking at delivery is certainly lower than the smoking level of women who book at their maternity service. And I think Jen said it was 3.5 or 3.6%. So it's pretty low in comparison to the national average. That doesn't mean we can't do better. And I think a linking up with Healthy Hounslow will actually help in terms of a community-based activity and additional community support. The second area, which is red, it goes back to Stephen, your comment about sort of health literacy and supporting parents to be more effective parents. And this isn't necessarily sort of borderline neglect. This is about how do we teach our parents to manage minor illness and to use primary care services, not necessarily the GP as the first instance, but farm community pharmacists and NHS 111 before escalating and pitching up at an A&E service. And as Joe's pointed out, our 0 to 4 A&E attendance is one of the highest in the country, and it's continued to be that for the last few years. That doesn't mean these children are admitted, so that sort of turning into an admission is really, really low. But actually, it has become almost sort of a walk-in centre and an immediate access service. So there is still some work to be done in terms of how do we support parents, how do we educate them, and finding the right forum through which we can advise parents that early activity in primary care is actually the most effective way to manage a minor illness for a child. The third area, now I'm not going to label on this one because it wasn't an indicator in the last one, but colleagues in the sort of services that reported against this did look at the Net Promoter Score for colleagues in Lambton Leisure, and it was reported as 31 per 100 as would promote the service in the last month, and it's now moved down to a red because fewer people promoted the service. To be honest, I'm not entirely sure why we're reporting against that. So if everybody agrees, I don't know why it's new in this area as a RAG-rated area, but it shows satisfaction level, but it's a snapshot. So I won't labour that anymore. We have a workshop in February. And I'm mindful that while we're going to be talking about our new strategy in February, it would be a good opportunity to talk about reporting, because I know that for many people around the table, this feels a sort of a bit of a blunt instrument approach to reporting. So that may be something that we pick up. Happy to take any comments or any queries against this report, but I'm presenting it as is.
Thank you, Kelly. And we can pick up the reporting at the workshop. Any questions or comments at all? Peter?
No, just a very good summary and very easy to read and get a snapshot of exactly where we are. Thank you to the colleagues. It's very useful for that.
Yeah,
Can I shout out to Martha, because Martha pulls this together and sometimes pulls her hair out by trying to get people to report and does the editing. So well done.
Thank you. I just had a comment, actually, Kelly, and that was about how we support parents in terms of managing sort of minor illnesses and not ending up in A&E. One of the things that I have observed is that when parents are trying to get urgent appointments from GPs and there's no capacity, they're not often told about the 111 service at the point of trying to get the appointment. And I think some parents don't necessarily default to that. And I just think it might be, maybe it's just my experience, but I just feel that might be worth just sort of being aware of that and see if we can do any work in that area, because not everybody immediately thinks of 111 if they haven't been able to get that GP. So if they've had contact with their GP services for an urgent appointment, but there isn't any capacity in the system for that, they could be seeking advice from 111 rather than going to A&E, but they're not necessarily, and I wonder whether that is being done enough in GPs surgery.
Just to respond that, understandably, parents are very risk averse when their children become unwell. And actually, if a GP appointment isn't immediately available, often they will go straight to the hospital. And the work that Josephina has done, and it's very comprehensive, and despite the full details that we have in terms of when parents turn up to A&E, and the data does tell us that they will come, bring their child immediately. The child will go to school or to nursery, and they'll go after school. So the timings of when children attend A&E is not what you would expect if they were able, if considering that there are lots of services available. So what I would say is, just for that, I think there is navigating what services are out there can be difficult for some parents, and we need to do a lot of work in terms of making sure that there are clear communications about what's the right service and when it's available, and then start to think about how do we create opportunities for diverting parents to the right services that are available, and to move them away from that idea that there's a big building around which is 24/7, which can be accessed, and you can see a paediatrician there. And I think when people have started to use that service, what we tend to see is that parents will turn up again, because it's a guaranteed access to a healthcare provision at a time when they want it, even though there is a waiting time.
Thank you. Stephen?
It's probably an operational thing, but if I don't say it now, I'll probably forget it. So it brings to mind in terms of the analysis of that patient flow. Because, of course, I sit here thinking that 1 in 10 of our school-age children are new entrants to the London Borough of Hounslow. So we know a particularly large number of those families come where the experience of other health systems is not as well constructed. So when Kelly's talking about there's a front door and it's well lit, that may be those people's only understanding of our NHS system. So actually there's a bit about in that analysis of why are they presenting, who's presenting, and what happens when they have presented, for us to, I spend an inordinate amount of my time at the back end of West Mids and the frailty cohort trying to understand stuff. It might be that we actually need to spend some collective time on the front end and the paediatrics bit to understand what's driving, because I would not be surprised that we'd find a higher or disproportionate number of new entrants to the borough presenting at that front door. I'd be shocked if we didn't. So it's how do we then link into them? Because one would have assumed they found themselves to someone like Amit and registered with a GP practice, but that might not always be the reality. So we do need to think about whether or not they show up in that flow at a disproportionate level, and what could we do? So I think there's a bit of us having to unpick some of that somewhere operationally, not here, but I think we need to do that.
So just to respond to that, there has been a working group that's been dealing with this for probably about 6 months, and we have all of that data. And one of the things that I did take the liberty to do, because I am the lead director for Director of Public Health for children in North West London, is that I use it as an opportunity to take it to the clinical, the Children and Young People's Clinical Leadership and Paediatric Reference Group. I can't remember the title, but colleagues, sort of lead consultants for paediatrics and general practice, sit on that board, and gave them the document with the key information. And we started to have conversations about why is Hounslow an outlier? Because we are so much of an outlier compared to the other Northwest London boroughs. Is that what are we doing that's different? And what action can we take that's over and above what you would expect for a population, given that we know the information, we know all of who's attending, when they're attending, what they're attending for, and what happens after they've attended, in as much as they've exited the front door. What we probably don't know enough about is what's the follow-up within community services to be able to support and have conversations with parents about what would have been the best place, and is there capacity to do that. And there are some areas in the country that do this quite well, and there are models that we can learn from if we have the capacity to do it. But we are a significant outlier in this area.
Recall when colleagues were giving us a presentation, there was a concentration about geographically where West Mids Hospital is.
Yes, you'd
So-
find that, yeah.
So that might in itself just be an easy driver. If you've literally just got to walk up or take one bus journey to get to West Mids from the school gate or from home, is that encouraging people to go there? Because I do think we had a bit of a concentration on just exactly where West Mids Hospital is.
Yeah, yes, we'll say yes, Stephen. There is a case that the geographical proximity is a driver that you find that if you look back on the University of Birmingham's sort of review of walk-in centres years ago, if people live close to an open access healthcare unit, they will go to that area. But we also see people travelling from Feltham and the west of the borough to the A&E services, which is surprising given that it does take time and effort to do that.
Yeah.
Yes.
Which GP practices are there, which schools are there, which services do we have located?
Like you're going to do that.
With a big sign. Yeah. Don't come
It's your new
here.
job. Okay, I've got. I'm going to quickly bring in Dr. Hilton, and then sorry, I haven't got your name tag. I can't see. Ah, Amit. Yeah, sorry, Dr. Amit. Yeah.
Without wishing to prolong that specific topic, I know that hospital colleagues are also interested in the timings of the attendances, and particularly what can be done in and around the West Mid area, but also after school hours, etc., to improve accessibility of the alternatives to attending the hospital site. So I think there's probably more that we can discuss in the borough-based partnership conversations with the hospital and ICB and primary care colleagues.
Thanks, Councillor Bath. I'll be very careful. I agree with all of my learned friends. So I won't repeat any of what they've said. So just to provide some additional assurance. So as well as being Hounslow Borough Medical Director, I'm the clinical lead for urgent emergency care for North West London as well. So this is a really hot topic for me, being the Hounslow Borough Medical Director, but also it's a hot topic. We may be the top, but it's a problem for every UTC front door. So there is a North West London Access Programme currently in progress, and it will be aimed to enter the primary care single offer, such that there will be an enhanced access offer across the whole of North West London. And it is to try and answer some of these questions. So that's one piece of work that's there. And I think the other item was covered by my colleagues. There was another program of work, but it escapes me. But I want to provide some assurance that we are really looking at this in a lot of detail. Sorry, I've just come back to me. The other element is the timing of this, as my colleagues have mentioned, is really between the 5 to 7 p.m. window, which is almost the most difficult time for primary care to respond to that demand. It's a phase where people are going from the in hours to the out of hours, and so we need to look at novel opportunities around how, like you mentioned, 111 interfaces with in and out of hours, but also how do we smooth the use of in-hours GP with out-of-hours GP services and seek every opportunity that we can, because in an environment where there's not any new money at the moment, we need to try and make best use of what we've got. So we're looking at every opportunity that we can. Thanks.
Thank you. That's very helpful. Councillor Sampson?
Yeah, no, that's certainly been my observation with the A&E department is the people that are attending, I find that they're going out of work hours. So I think that it's definitely like what you say, it's between that after 5 p.m. We do need to look at that, but it's definitely to do with work commitments.
Thank you. So obviously we know there's work going on around this, but okay, thank you. Comments noted. I think we'll move on then if there's no other questions, which is Kelly again. This time it's the next year's health and wellbeing strategy, isn't it? We need to discuss our plans and how we're going to move forward with that.
Yes, so just to advise, and we'll pick this up in the February workshop, we have started, so Anne and Martha are leading on the work to develop the strategy for 2026. We've kind of noted, Stephen, your comments in previous meetings about why do we have a 3-year strategy and perhaps what we need to do is have a rolling strategy, given that most of the priorities that we have that we've got, you do generally take more than 3 years to deliver there because they're quite significant sort of complex difficulties that have been quite perennial. So I just wanted to assure us that we are picking this up in the February workshop, and in that kind of planning process that Anna and Martha are leading, there is work going on to look at current data, where our areas of priority are, to start to consider what we would want to be our priorities as part of the next strategy, and also to start, and following that workshop, there will be, there will be a series of pitching up to every forum. It's all seven. Yeah. 7 in March, which Public Health are willing to do, Mr. Forbes. Yeah, and we have booked time slots to have yeah, wait, and well, March and April. March and April. It's all March. Where we book slots to have proper conversations with attendees, World Cafe style, so we can get people's understanding of what they understand to be the priorities for the borough. So we get that insight of not just, well, we're not just focusing on what our priorities are and what the data tells us, but more what our residents tell us is important to them in terms of health and well-being. So that will be the first round of engagement. We've got a good lead in. We've got 18 months lead in time. So we're going to do this really properly and really thoroughly. Well, more so than we did last time. But actually, we had a good process last time. Pauline and I were quite robust. But this is going to be a step up. Did I miss anything? There you go.
Have you got nothing planned for March?
You can be there. You can be there with us on video.
Thank you. I just wanted to say that, I absolutely support. I think Kelly and I had a discussion. I absolutely support the the sort of intention of going to area forums, because I think we really want resident engagement. I think, and it gives you really good flavour of what kind of problems people are presenting with our area forums, particularly if you are there before the meeting starts. I think that's really important that you're available, because there's all sorts of issues around, health, well-being, but people's lives in general, and some of the problems that they have. So that would be really good. Okay. Any questions or comments on that? No. Okay, so we're going to proceed with that, and you'll come back to us just obviously next time. Let us know how we get on with that. Thank you. Then moving on, is any other business? I haven't been advised of any other business. No. Okay. If there's no other business, then the date of next meeting is the 30th of April, and that will be at 4 p.m. And I think say goodbye to everybody. Thank you for your contributions. So thank you for anybody that might have joined online. Thank you. Good night.